Hi, thank you for coming to APTA's next virtual conference. The title of this presentation is Movement Screening Test for Athletes, Tools for Effective Clinical Practice. I'm Megan Warren. I'm a physical therapist and professor in the Department of Physical Therapy and Athletic Training at Northern Arizona University. My co-presenters will be Nicole Chimera, an athletic trainer and associate professor at Brock University, Monica Leininger, an athletic trainer and associate professor, and my colleague at Northern Arizona University, and Craig Smith, a physical therapist and owner of Smith Performance Center. This presentation will start with me talking about the epidemiology and mechanism of sport injury. Next, Nicole will talk about some of the movement screening tests. Monica will then talk about the association of movement screening tests with injury research, and this will focus on a lot of the work we've done since 2011, as well as other researchers' work. Craig will then talk about recommendations for movement screening tests to use clinically, focusing on a community-based program, and then we'll all be back at the end for next steps and discussion. Before I move forward, I want to give a big shout out to the NAU Lumberjacks, the student athletes who have been our research participants in this work. We could not have done this work without them. I also want to give a shout out to the dedicated professionals, physicians, and athletic trainers at NAU Sports Medicine, as well as the strength and conditioning team. Again, they were instrumental in us being able to complete the work that we've been doing with NAU Athletics. NAU is an NCAA school with 5 men's sports and 8 women's sports, and we've been working with all of them at least once in some of the injury surveillance research we've done. Recently, we started working with competitive and recreational athletes. At NAU, we've been working with the intramural sports, which is 36 sports per year, and the sports club, which is more than 30 club sports. We also did a little bit of work with club sports at Damon College in upstate New York. So on college campuses, a little less than 500,000 student athletes participate in NCAA sports. 4 times as many, or 2 million, college students play club sports. And of the students surveyed, 41% of college students participated in intramural or club sports. So on college campuses, there are a lot of students participating in several different types of sports. When I talk about injuries, I'm focused on musculoskeletal injuries, and I want to make that clear that to differentiate from other types of injuries and illnesses that may occur with athletic participation. The NCAA has an injury surveillance program, and that's been going on since 1982. It allows athletic trainers to report injuries in each of their sports every season, and that really results in this really robust data set for national level analyses that can be done on injury in NCAA sports. This table is taken from some of the work done with the injury surveillance program, and it focuses on all sports and injuries in all sports. They split up competition and practice, and then overall. The number of injuries is the 3rd column, and that's defined as an injury, something that requires a student athlete to go to the athletic training room for intervention and miss 1 day of training or competition. The next column are athlete exposures, which is the denominator for the injury rate. And an athlete exposure is 1 athlete participating in 1 practice or 1 competition. Using those as the numerator and denominator, the estimated injury rate per 1,000 athlete exposures is 6 for all sports, a little higher for men's sports and a little lower for women's sports. Recently, a paper was published with injury rate in collegiate club sports, and overall that injury rate was 15.8 injuries per 1,000 athlete exposures, with both injury and athlete exposures defined as the same as the injury surveillance program. I also included an example of a men's sport, football, and women's soccer to show differences in men's and women's sports. Now, if you look at the 6 and 15.8, you say that there's a big difference there, but this This paper had a much smaller sample size, and the authors caution you on comparing the injury rates between the injury surveillance program and their paper that they publish. But it does show that there are injuries that are occurring in club sports as well as in NCAA sports. This figure is taken from the injury surveillance program again, and it shows the proportion of injuries that are occurring in practice and competition. The dark bars are competition, and the light bars are practice. And you can see that almost without exception, most of the injuries are occurring during competition. Notable exceptions are women's cross country and men's and women's tennis. Our work, we focused on non-contact injuries, and the reason for that is that they are not uncommon. 20% of injuries during competition were non-contact and 40% during practice. And the other reason we focused on them is non-contact injuries cause about 70% of ACL injuries. Our work, we also focused on non-time loss injuries. So this would, our injury definition was that a student athlete had to report to the athletic training room and receive intervention, but we didn't include a time loss component to that. And it's well justified in this because this Kerr paper reported that about half of the injuries were non-time loss. So putting a time loss structure on those, you may be missing some significant injuries. On the population level, the National Health Interview Survey reported that 8.6 million Americans received medical attention for sports and recreation injuries. The medical attention was primarily going to their primary care physician or the emergency department. And you can see that in our age groups of interest, we see fairly high level of injuries, and those would be the ages that exist on college campuses. Although most of the injuries were not serious, 20% of the working age respondents lost 1 or more days of work, 3% required a hospital stay, or required assistance with ADLs for more than 6 months. So those certainly are significant injuries. Why we think it's important to study injuries? Well, guidelines across the world have said that physical activity and exercise is important for individual and public health, but current injury is a barrier for being physically active. Injury is the #1 reason that athletes reported quitting participation in sports, and there have been reports that show decreases in short and long-term health-related quality of life with injuries. The burden of injuries is also fairly significant. This paper used disability-adjusted life years, or DALYs, which are just a sum of years lived with disability plus years of life lost. If you look at years lived with disability, low back pain has the highest years lived with disability. Other musculoskeletal disorders is 4, and neck pain is 6. I included diabetes and opioid use just to provide some context. When we look at overall DALYs, low back pain, other musculoskeletal disorders, and neck pain are certainly high, but they are lower from the years lived with disability, because although these musculoskeletal injuries really can cause significant impairment for morbidity, they don't really affect mortality much. Next, I want to talk about injury etiology, and that's why a particular athlete may be at risk in a given situation or how injuries happen. If you haven't had a chance to read this paper, A Dynamic Model of Etiology in Sport Injury, the Recursive Nature of Risk and Causation, I encourage you to pause this presentation right now and get this paper and look at Figure 2, which is the model. I'm going to focus on parts of it, focusing on the predisposed and susceptible athlete. So a predisposed athlete is one that is at increased risk because of intrinsic risk factors, and they could be age, flexibility, movement, asymmetry. They may be necessary, but seldom sufficient to produce an injury. A predisposed athlete can become a susceptible athlete with extrinsic risk factors, and those can include things like game conditions, equipment, officiating decision. But as you know, the mere presence of risk factors is not usually sufficient to produce an injury. And the interaction of these risk factors prepares the athlete for an injury, but they need some type of event or situation to cause an injury. That inciting event is a necessary cause for injury, and it's the final link in the chain that may cause an injury. But we also know that with given intrinsic and extrinsic risk factors and an exciting event, not everyone will get injured. And there may be adaptations that the athlete undergoes to based on the intrinsic risk factors. Also with injury, not everyone will return to sport. Hopefully a substantial number recover and are able to return to sport, but there are some who just stop participating. There's a complex interaction of these risk factors, and we don't really know what they all are yet. But focusing on modifiable risk factors can be important because those are ones that are potentially amenable to physical training or behavioral approaches. An example of how this all works with an ACL injury due to valgus trauma to the knee, intrinsic risk factors could be female and previous knee injury, extrinsic rainy day playing outside, but even in the presence of those two things, not every female with previous knee injury playing on that soccer game would have an injury. The inciting event may be the position in the field of play. It may be distant from the injury event, but that's the necessary cause for an injury. Just 2 months ago, Bardal published the International Olympic Committee consensus statement, methods for recording and reporting of epidemiological data on injury and illness in sport. And this consensus statement is proposing mechanisms of acute and repetitive with a presentation of sudden onset or gradual onset. And the examples here show you, if we look at repetitive gradual onset, a swimmer experiences gradual increase in shoulder pain over the course of the season. Diagnosis, rotator cuff tendinopathy on an MRI. For the sudden onset injuries, the injury mechanism classifications include contact and non-contact, and then if contact, indirect or direct contact. There still is a lot of debate in the literature and amongst researchers on how to best define injury and classify injury. And there have been some sport-specific consensus statements in rugby, for example, but this is the first time that for many sports put together that there is a consensus document on injury. So this may be very beneficial moving forward. So that was a brief introduction of epidemiology and mechanism of sport injury. Again, Nicole will pick up next with a description of the movement screening tests. Thank you for listening and have a good day.